The primary focus of the study that we're presenting on here at SHEA is looking at sort of the sense making that inpatient clinicians use to make sense of why antibiotics are overused in their setting. And we utilize a qualitative approach, which means that we go and we interview clinicians and just ask them, like in a very open-ended way, can you explain to us what are some of the reasons why patients may get unnecessary antibiotics? And when we went to analyze the data, one of the most common and repeated themes that occurred across the data, and we gathered interviews from 3 different health systems with 60 people. One of the things that came across repeatedly was fear. And so the clinicians that we spoke with said that one of the large reasons why in the inpatient setting patients sometimes get antibiotics that they don't need is because the prescribers themselves have a very strong emotional reaction that drives this use of antibiotics. And so sometimes you might hear this in other settings in which a clinician will say, yeah, we use antibiotics to comfort ourselves. And so this study was really trying to unpack that and understand when they talk about emotions, what are they talking about? And what we really found is that this emotional response is sort of embedded in a more complex array of factors. So first of all, you have the stage that is really set for prescribers to experience this emotional reaction, which is the fact that medical practice is very uncertain. So clinicians are constantly managing and navigating the uncertainty of a very sick patient who's in front of them. They don't know what's wrong. They might not have all the diagnostic information that they need to identify what the patient is sick with, but they're very sick, and that is coupled with a very strong sense that they have a very heavy burden of being responsible for making sure that this sick person in front of them is okay. So we have uncertainty and we have this burden of responsibility that sets the stage. And then clinicians are working in very complicated and complex environments that are characterized by a number of factors that also set the stage for this emotional reaction. So things like time pressures, a fear of medical legal ramifications. They are dealing with sort of constant assessments of their competence by their colleagues as well as their patients and the families. And finally, it's a very busy setting in which there are multiple teams of clinicians who are working together, and that sort of the handing off of patients between clinical teams is another layer of uncertainty. So we have uncertainty and we have this burden of responsibility that is coupled, sort of working together, and that when a clinician is faced with a patient that may be infected, but they don't really know what's going on, what we found is that our respondents described this very strong emotional reaction that they get that then triggers an urge to do something. So it triggers an action orientation in which they quickly put a patient on an antibiotic, a broad spectrum antibiotic, in an almost automatic and unquestioned way. And this sort of urge to act, so fine, you start the patient on the antibiotic, and one of the major principles of stewardship is that once you start the patient on the broad spectrum antibiotic, you get the laboratory results back, and maybe you pull off the antibiotics or you make them more narrow spectrum. But what we found is that when people talked about this emotional driver of prescribing, that it applied just as much to the act of stopping antibiotics or de-escalating antibiotics. So throughout the continuum of the prescribing pathway is this constant emotional experience of fear of something happening to the patient, fear of being wrong, fear of being sued. And so this emotional reaction is constantly there. And I think when we think about stewardship, we don't often think about that aspect. Although when you talk to antimicrobial stewards, they will say that they understand this, but we haven't really incorporated it fully into our stewardship interventions. And so